My name is Michelle Campbell. I'm the Executive Dean of the Faculty of the Health Sciences. Most of you know me. And we are here because this is the 25th year that ACU has been formed. We were around earlier with predecessor Teachers College, but we all came together 25 years ago to this wonderful, glorious university we call ACU. So we have a whole schedule of events planned for this year, celebrating the 25th year. One of the events is the seminars, the academic seminar series, and the Faculty of Health Sciences is the first faculty to run this, and then the others. And the other campuses, the other faculties have their events later on. So can I thank you all for coming along to hear our guest speaker, who I'll introduce in a moment. But can I please invite Cassandra to come up first and do a welcome to country.
So Yama Melius, Gurungai Nyale, Cassandra Nyaya, Gamaroy Nyaya. I just had a brain freeze, sorry. Dawan Gurungai Winningala Nanyini, Gugu Gurungai Winningala Nanyini, Wayama Gurungai Winningala Nanyini. For you, Polly, I'd like to say in the stories that you're sharing tonight, Bayami Wallangaba, Banal Ninanya, Gimbla Wee Murray-Gully, Ninanyu Gimbla Giru. In the language of my old people, that translates as hello friends, this is Gurungai country. We acknowledge the Gurungai land, we acknowledge the Gurungai elders, and we acknowledge the Gurungai ancestors. That last part was a blessing for the stories that you're sharing today and the journey that you're about to be taken on with Polly, and asking the custodians of this country to walk with you in that story and to be with you and guide you as you share about stories tonight. Thank you.
Thank you. Now, can I just do one more sound check before I move on to Polly? Can you hear me, and did you hear Cassandra? Yes? Yes? And Brisbane, yes. Okay, good. Thank you. Okay, so I will move on to introduce Dr. Polly Bednash. Polly is an adjunct professor with ACU. She's been a friend of the faculty in the School of Nursing, Midwifery and Paramedicine for many years, and we invited Polly out here to be our international keynote speaker for this seminar series with the Faculty of Health Sciences. So Polly has up until recently been the Executive Director and CEO of the American Association of Colleges of Nursing in the US. And she did that for many years, from 1989 to just last year, 2014. So prior to serving as Executive Director and CEO, Dr. Bednash headed up the Association's Legislative and Regulatory Authority and the programs as Director of Government Affairs. And you may not know, but Polly's office was right there in Washington, DC, close to all the government bodies, so that would have been really interesting. In that post since 1986, she directed AACN's efforts to secure strong federal support for nursing education and research, and coordinated new initiatives with federal agencies and other foundations. So Polly is also a fellow of the American Academy of Nursing and a member of the Nursing's National Honour Society Sigma Theta Tau, along with somebody else in the room, Mary Courtney. Where is Mary? Dr. Bednash has served on multiple boards and commissions involved in nursing and allied health services. Her publications and research presentations cover a range of critical issues in nursing education, research, clinical practice and legislative policy. So I'm very pleased to be able to introduce Dr. Polly Bednash. Thank you, Polly.
Thank you, Michelle, and I want to thank all of you for coming today. It is very much a privilege to be a part of ACU and to be an adjunct professor, and having known and worked with both Pauline and Michelle for a number of years, it's really an honor to be here as your speaker. And I hope that today we can have some conversation too, besides me doing a formal presentation. When I was asked by Michelle to do this, she said it would really be nice if you could focus broadly on healthcare, not just nursing, which is where most of my work has been, and to think about what's happened in healthcare over the last 25 years, the history of ACU and how it's changed. I have spent a bit of time thinking, obviously, about what's been going on in our country, But also, as part of this, I wanted to know whether or not there were synergies between what we are experiencing in the U.S. and what you're experiencing here in Australia. And as probably no surprise to you, the issues are very much the same for a lot of us. Now, we are looking back at an enormous transformation of healthcare over the last 25 years. And it is absolutely important for us to think about the fact that we have two different cultures about healthcare is given. You actually believe in this country that people deserve healthcare. It's not so sure about that in the U.S., and I'll talk more about that as we go on. But some of the issues that we're dealing with are the same. There are the issues of how it has changed and how we deliver care, and the fact that we are now with this transformation. I hope one of the things we can talk about today is the implications of that for how we prepare health professionals for the future. You have an array of health professions programs here. I'm very impressed when I look at this list here. It's not just nursing, it's a whole array. And the way the healthcare system is changing is going to affect all of us in our lives and how we care for people and what we do for them and how we partner with them, which is going to be a major theme here. So 25 years ago, the hospital was the locus of control for healthcare. Everything happened in the hospital. Students went to the hospital only to train. We also saw that people went into the hospital for extended stays. They didn't go in for just a couple of hours or a couple of days. In the U.S. today, actually, most health stays in the hospital are less than 24 hours. You go in, my husband had hip surgery, you all will get a chance to meet him. He had hip surgery, he went in one morning, and the next morning went home after his replacement was done. So there's this rapid turnover of people. And we used to put people in the hospital and keep them there for quite a while we cared for them. And the other thing that was happening with healthcare and how it was delivered is that it was a very paternalistic system, often driven by physicians in charge, telling everybody what they should do. And if the patient tried to do anything about it, who do they think they are? The patient was not to drive this. It was the physicians, mostly men, who were dominating. And people were paid no matter what they did, whether they got a good outcome or a bad outcome. In the U.S., we have this system that's called fee-for-service. So the more services you do for people, the more people were paid. And a lot of times, it didn't matter whether what you did actually improved the patient's health status, or if there were errors, that wasn't a problem. They still got paid. And for heaven's sake, if a patient tried to drive any of the care, one of the things that would happen is that if a patient tried to challenge a physician and decided that they didn't want to stay in the care, there were records put in their charts about how they were going against medical advice, branding them as being uppity. Who did they think they were? That it was the physician that was in charge of all of this. So now we're seeing a transformation, and the word transformation is thrown around a lot in healthcare today in the U.S. And one of the things that I did was say, well, what does transformation really mean? What does that represent? And one of the things that it means is revolution. And we are seeing a revolution in healthcare in the U.S. and how it's delivered and who's in charge. And we're moving away from an experience focused on acute episodes of care to a focus on the full experience of health, and how we avoid illness and how we help people do the right thing themselves for their own personal status and for what we do for patients. So the driving overarching theme that we see is what's called the triple aim. The triple aim has having three principles as the focus of what healthcare should do, and that is to improve the health of populations. Population-based care, something I'll talk a little bit more about, is a huge issue. What do we do for groups of people? What do we do for all the diabetics we see? What do we do for all the older adults with cardiology disease? And what do we do for managing chronic illness in a population? What do we do for children? How are we managing the care of children? So focus on populations and how we drive better care towards them. Also, the interest in having the patient experience improved in that care experience, having them actually believe that they are a part of this and that they are partnering with the provider, and they actually can see that they are part of making the decisions about what should happen. And then there's the issue of costs. Now, in our country, we've had a lot of conversation about quality and access, but the big issue for everybody is cost. huge amounts of money spent on healthcare in your country and ours, and I do have some statistics there. So the focus on accountability and what we do for people and what we do to improve their healthcare is driving everything now. And there's a broader look at what happens to people. Where do they live? Who are they? How much money do they earn? What kind of a support network is there out there? There's an interesting man whose name is Lloyd Michener, and I don't know if any of you are interested in public health or in community health, but it would be worth looking at his research. He's a physician and a public health expert. And one of the things he did is he looked at communities, populations of communities, and said, well, what is their health status? And what has to happen in this community to improve their health status? And one of the things that he looked at was whether or not there were places people could buy food. These are called food deserts. I don't know if you have them here, but we have food deserts in the U.S. where you have inner city communities or rural communities where there's no grocery stores within 10 miles. And he looked at what happens about the physical surroundings of where these people live. Do they have street lights? Do they have sidewalks? Do they have playgrounds? And he would go into a community, bring grocery stores in, bring in fresh fruits and vegetables, bring in healthy food, help them repair the sidewalks, help them put in street lights, improve the park structures. Now that's not usually what we think about in healthcare, is it? But guess what? He was able to document that the rates of diabetes and hypertension went down. So it's looking at a population and thinking very different about how we avoid the illness experience and create the environment that will allow them to live a healthy life. Whoops, there we go. Okay. So the next big issue for us then is, what does it mean to do quality care? What does it mean? And access is part of that in quality care. And how reliable are we in what we give to people in the way of care and what we see in the way of outcomes? Cost, quality, and access. Those are the driving issues. How do we be sure that what we're doing about spending money is doing the right thing for people? In the U.S., we've been able to show that there's a huge amount of money that's spent for unnecessary care. Right here is, you see at the bottom, it says the $121 binky. You know what a binky is? It's a pacifier. Now, what do you pay for a pacifier in a drugstore or a department store? $2, $3? So hospitals are charging patients $121 for a pacifier to put in their baby's mouth. These huge expenditures, they've documented huge expenditures for aspirin, drugs that are inexpensive that you can walk in to buy in any drugstore. And so there was more than enough unnecessary spending to cover almost everybody who needed health care in the United States. And so this is a huge issue for us, what's happening about health care expenditures. And you have an issue for this too in your country. I looked here, and you've had a lot of study done here about what's going on with expenditures. However, you don't spend anywhere near as much as we do. So almost 18% of our gross domestic product is spent on health care. And oh, by the way, most people don't have access to health care. So we spend more on health care in the U.S. than any other country in the world. And our health care outcomes are not so good. In fact, there's pretty good documentation that the more you spend on health care and the more you do for people, the higher the risk that something bad will happen. Here's hip fracture. To your left is the lower spending. To the right is the increased risk. So the more money that was spent on somebody who had a hip fracture, the higher the risk that something bad would happen, because we're doing more than we need to do. Same thing here for colorectal cancer. Same thing here for myocardial infarction. So the more we spend on health care, the more likely we're doing unnecessary things and putting people at higher risk. And this is the particular citation, should you want it. And by the way, I did say to Michelle that she can put these slides up on the web, and if you want any of them and you see anything here that you're interested in having, you have access to them. So you also in this country have some concerns about unsustainable growth in the costs, but Aussies tend to be a lot healthier than those of us in the US, so we're jealous. You're doing some things right, obviously, maybe because you're not spending as much money as we are on health care. So it's not always bad. Now, interestingly, you have Medicare and we have Medicare. But Medicare in the U.S. is different than your Medicare. Your Medicare is the general public form of health care for everybody. In the U.S., Medicare is only for people 65 years and older, and some disabled individuals who are younger than 65 get it. But the day you get a job, you start paying a tax on Medicare. You pay tax, your employer pays tax on Medicare, but you're not eligible for it until you're 65. And in the U.S., there's this sense that, well, we'll talk more about that, that all of this spending is creating an enormous economic engine in the country. So some people are concerned that to cut back on the cost will cut back on this huge economic development that occurs around the expenditures in healthcare. That's the technology, because most of the time it works, like we did get it working here today, and the infrastructure. But the other is the employees who are earning incomes and then themselves are paying taxes to support the infrastructure in the whole country. This is an interesting piece that I have here that was a study that was reported in the New York Times just recently about registered nurses as the new factory worker. Now, for those of us who are registered nurses might see that as a bit offensive to be considered a factory worker. But here's the analogy that they were making. 50 years ago, the middle income worker was a factory worker, someone who worked in a factory making cars, making washing machines, making steel. They were the factory workers who were the bulk of the middle income earners in the U.S. Now, the major middle income worker in the U.S. is the registered nurse. And that population is growing and growing. It's a source of financial stability for our economy. So again, despite the fact that we're spending a lot of money on healthcare, it's actually bringing an enormous level of middle income earnings to a lot of people. And it's expected to continue to see growth. And one of the things you know about nursing is that you can't outsource it. So we can't send somebody to China or Japan or Vietnam to get their nursing care. So it has to be right there in the U.S., and it continues to grow. And it is the one career in the U.S. that is just exploding at all levels, at the basic level and the advanced level. So much of the concerns about cost were all about whether or not we were providing enough care, too much, the right amount, like the three bears, too big, too small, just right. And so how much is just right? And we have this real dilemma in the U.S. that the culture of the U.S. is that you only deserve health care if you work for it. You shouldn't just get it just because you happen to be a citizen of the U.S. And if you want it, you go out and get a job and get paid and get a benefit. Interestingly, most of the people who are uninsured in our country have jobs. But they work for places like Walmart or Target or Burger King, where they get no health care benefits. And most health care benefits come through your employers. Now, you did move to a privatization scheme a few years ago, but then came back. And I know that you have Medicare and you have private insurance. So you have an interesting hybrid about how you pay for it. So the issues are similar for our countries, but you have actually had a more noble approach to believing that everybody deserves care, and you are to be envied for that. And I think the U.S. is one of the few countries in the world that doesn't provide automatic health care coverage to everybody in their citizenry. Now, quality, too, is an issue for all of us, and you've had a number of commissions looking at the issues of safety and quality and the quality of care and the outcomes and how decisions are made to apply certain kinds of care. We've had the Dartmouth study on healthcare, which has documented that there are huge variations in costs and the amount of care depending on where you live in the country. And the more physicians there are located in one particular area in the country, the more likely you are to get that care and the higher the costs you are going to pay for the care you get. Now, you would think that if there were more people, there would be more competition, and so people would have to compete for the services and the care. That's not what happens. The more they locate, and you'll see places like New York City, Washington, D.C., Boston, San Francisco, these huge metropolis with lots and lots of education and a desirable place to live, and that's where the providers locate, and that's where the costs are higher. Maybe because it costs more to live there. So the Dartmouth level said, again, what you earn, where you live, what type and level of care you receive are all intricately interwoven here. We have had some recent work in the U.S. to try and have some legislation passed that would give everybody health care. It's what's called the Patient Protection and Affordable Care Act. It's been hugely controversial. And we have the equivalent of your Liberal Party, and it's called the Republican Party. And they have been very angry about this legislation and have tried on several occasions to get the law overturned by challenging it in court. There was one Supreme Court hearing which prevailed that, in fact, the legislation was constitutional. There's a second one going on right now. And again, the American public isn't so sure whether this is a good thing to do, to have an opportunity for everybody to get health care, because there's a tremendous distrust of the government, and the government coming in and controlling what they can get in the way of health care. And they hear stories about Canada or Australia where people have to wait for care if they're on the publicly funded kind of system, and they decide that if we got that kind of system, you'd have to wait there too. The reality is, in many instances, you have to wait anyway because the person you want to see has got a lineup of people waiting to take care of them, so you got to wait anyway. But there's this very, very big distrust of the government doing anything to control your health care, telling you what you can do, what kind of care you should receive, and so it's not been the most popular legislation. And then we have the problem of quality of care. And it says, that is a typo. So you were expecting the collagen injection in your lips and the liposuction on your hips. It's a funny little slide, but it's about a dirty little secret, isn't it? And this is a woman's worst nightmare. You better get it right if we do it, right? You know, the history is that when we put people into our acute care systems, bad things happen often. Very bad things happen. Medical errors abound in many places. You've had a look at the issue of quality in your country through the Australian Commission on Quality and Safety and your National Health Performance Framework. We had a study done by the Institute of Medicine. The Institute of Medicine in the U.S. is a major health policy think tank that looks at big issues in health care. And they did in 1999 release a document titled "To Err is Human, Building a Safer Healthcare System." And in this document, they did in fact report that every year 100,000 people die from medical errors. That's the equivalent of a major airline crash every day. And that doesn't count what happens when we have errors in surgery or errors in outcomes where people get hospital-acquired infections, or they get catheter-associated infections, or they get the wrong limb amputated, which still happens. So we have a tremendous concern about quality. And despite the fact that this report went out 16 years ago, we really haven't seen a lot of change. And part of the issue is the culture that we've created in healthcare of dominant views about what should be happening and who should be in charge. And it's something we'll talk about a little bit. Now, one of the things that we're doing in the U.S. to try and incentivize quality is to say, well, we're not going to pay you anymore when something bad happens. And have you ever heard of what we call the never events? These are the things that should never happen when someone goes into the hospital. Pressure ulcers, catheter-associated infections, hospital-acquired infections of any kind. And what's happening now is that the insurers and our government-funded system is saying, if those things happen, we're not going to pay you for the bad things and the cost of taking care of the bad things. So there's this attempt to incentivize people through the stick of reimbursement and having your reimbursement cut. Also, they're saying that if you actually do really good care and get better outcomes, we may pay you more. So it's to incentivize the systems to do the right thing through the dollars. And so the focus is on improving the patient outcomes, patient satisfaction. Patient satisfaction is an interesting thing. All providers who receive funding from insurers or from the federal government have the patients that they're caring for have a survey that they have to fill out. And it's called the Patient Satisfaction Survey. And the hospitals have to have patient satisfaction surveys. Was the room too noisy? Was it clean? When you put your light on, did the nurse or the doctor or somebody come to see you and take care of you? And there's a huge penalty if you don't get a good rating. It can take a big chunk out of your reimbursement. So again, it's this stick that they're using to try to incentivize people to do the right thing. And to some extent, maybe we shouldn't care if it gets us the right thing, so that patients actually get the care they deserve and they get treated with some respect. So it is a move to what's called patient-centered care that the Institute of Medicine need to have happen, to actually put the patient at the center of care, because after all, it's about their lives, isn't it? It's not about who we are, it's about what we're trying to do for them. And seeing the patient as partner and as an important guide of what's going on in healthcare. The Veterans Administration healthcare system in the U.S. actually has created a model of care that they call the patient-aligned care team. And it does put the patient at the center of what's happening with them to make decisions and share information, and they use a team of providers to do this. So that creates a challenge for us as healthcare providers, because we now have an engaged patient who should be engaged. Let me ask you, how many of you have ever gone to the internet to find out something about your own health status or a family member's status? The internet. And of course, everything you see on the internet is true.
Of course.
Right, exactly. So you have an engaged patient who often will come in with a pile of stuff that they've gotten off the internet, and you want them to be engaged, but you've got to help them really cipher through what they're getting out of Wikipedia, or they may be getting the latest evidence out of some state-of-the-art new research project that they saw. I tell people that when our dog, our beloved golden retriever, had to have surgery on her nose, she had a tumor on her nose, then it was a very deadly mast cell tumor. The first thing I did was go and look up every veterinary medical study that had been done in the country and try to find out whether or not she should have a wide excision surgery, if she should have chemo, should she have radiation, what should happen. And I went in to see the vet with my big pile of stuff. And I did the same for my husband's hip surgery. I do love you, dear. I do for you too. But it empowers you to really be able to be a part of it, but it challenges you as a provider, because you've got to determine whether what they bring you is truth, and then you have to respect their right to come in and bring this to you and be a part of that conversation in a very different way. And by the way, the vet that we saw, who looked like she was 12 years old, took us in and talked to us about her experience with this particular type of tumor, what she was going to do, how much it was going to cost, what her outcomes were, what we should expect in the way of a recovery period. Now, shouldn't we all get that when we get health care of all kinds? Not just my dog. We should all be able to feel that we can get that same kind of partnering and clear information about what's going to happen. And by the way, she did a beautiful job. She took a big chunk out of my dog's face, and she looked perfect afterwards, and I thought, I wonder if she does people. So we need to respect the patient's right to have this information, and every one of you is out there looking, doing the same thing, right? Right, keep turning this thing off, don't I? Okay. So how does it then create this partnership, or does it create a dyad of conflict about who's in charge? And you have to think about that a lot. Now, one of the things that's happening in the U.S. that's illegal here in Australia, and you should be very happy about that, is what's called direct-to-consumer marketing by the pharmacy companies. And the purple pill is Nexium for your acid indigestion, and it's one of those, we call it lusting for that, but they spend billions of dollars in advertising drugs. So here's an array of ads that were in that famous medical journal, Better Homes and Garden. Here's Botox. Boy, wouldn't you love to look like that? That skin is beautiful. These ads are powerful because they present images that you lust for, or they present a problem you may be feeling with a hint of hope that you're going to get better if you will just use this drug. These are in magazines of all kinds. They're on TV. There are billions of dollars spent advertising. Now, it's illegal to do that in Australia, I'm told. But I did read something that said that one of the things that the pharmaceutical companies will do is have a health fair, and just happen to have literature about their drugs here in Australia. So here's the chronic migraine. She looks really unhappy, and so she really needs a drug. Here's Premarin for your own lubrication and depression. Now look at this picture here. Wouldn't you rather look like that picture than that kind of gray, sad, wind-up doll? They're powerful images. Now, I'll give you one guess as to what drugs are advertised in Golf magazine. Viagra and Cialis, yes. That's the only thing you see in Golf or Money magazine. So you have now this whole effort dedicated to helping people really look at the information, understand what's happening, to be more literate in what's going on. And this huge, huge array of tools that are being prepared for people. All of us have iPhones or some kind of PDA device. How many of you own these little things you put on your wrist so that you can see how many steps you took and how much calories, and they have them that tell you how to sleep? And I dare you to go into the apps, to iTunes or any of the app stores, and type in health and see the hundreds of apps that come in. These are just a few of them. Doctor on Demand, Care Zone, Health Grades. They are now apps out there to tell you what the outcomes are of care providers, so you can go in and rate them and see if you want to see them. iPharmacy, Clinical Advisor, Consumer Union, Consumer Decide. One of the magazines in the U.S., Consumer Reports, has recently been printing stories with data about outcomes for certain kinds of procedures and rates for hospital-acquired infections with the hospital's listing. And you can look at some of these and see some are really good, and some of them you're thinking, I'm never going there. And it's around giving people the opportunity to have the information they need to make wise choices. Unfortunately, often people make choices because they think somebody's nice, or it seems to be a nice place, or it's close to where I am. But this is actually empowering people in a very different way and creating this, again, partnership that's going to mean that we have to practice in a very different way. That means, and one of the reports that came out of the Institute of Medicine was called Crossing the Quality Chasm, Building a Bridge to the Future. And it really was a report on how we have to change how we educate health professionals. And it didn't say physicians need to be educated differently, nurses need to be educated differently. It said all health professionals need to be educated differently so that they can deliver what's called the STEEP, safe, timely, effective, efficient, equitable, patient-centered care. And it means we have to be different kinds of learners and partners. So what are the competencies that we'll need for the future to deliver patient-centered care? And what are the care issues that will frame how we work? In the U.S., we have a markedly aged population, looking like me. We have a huge baby boomer population that are turning 65 and older. We have an enormous problem with chronicity and chronic illness, with people with multiple chronic illnesses, and that's not just older adults. It happens with pediatric populations too. We have, again, these highly involved patients with this marketing. By the way, if you're ever in the U.S. and listening to the TV, you need to listen to one of those ads, because you see these happy, smiling faces, and people are hugging each other and looking very pleased. And the announcer says in this really quiet voice in the background that you can just barely hear if you pay attention, and it says, may cause blindness, death, stroke, heart attack, and goes on and on and on and on with this. And if you listen to that, you'd run screaming from the drug, but what they see is the pictures and these beautiful smiling faces. The ads in the magazines will have the picture and then 2 pages of side effects. But nobody looks at the side effects. They look at the picture here again. We also have this technological revolution, 3D printing of body parts. I saw something recently about some experiments that are being done with mice hearts, where they're being able to take a 3D projection of a mouse heart and inject stem cells into it, and within a week, this little mouse's heart is beating. This is a new, entirely different world for us. We have distance delivery of services for people who are in rural areas where there's no access to health care, where they have their computer and their screen, and you deliver care that way. We have virtual intensive care units, where you will have an expert intensive care nurse at a computer working with rural sites to give expert advice to the nurses or the physicians or others who are providing care in these rural sites that don't have the technology or the expertise. So we see this distance-mediated healthcare delivery. We also have such a knowledge explosion, and Wikipedia does have some good stuff, and they say there are 40,000 clinical trials in process at one time. How can anybody know everything they need to know about delivering health care? You can't. None of us can. Now, when I graduated nursing school back in the dark ages, you graduated and you thought, God, I got it all down pat now, I know it. Well, it's not true. It wasn't true then. It's not true now. And so what we need to create is not people who are instrumentalists who can put things into people. We need to create knowledge workers, people who know where to seek knowledge, who know that they don't have it all, and know how to find what they need to give the absolute best care. So we have also in the U.S. this transformation of how care is being organized and delivered and put together into consolidated networks. One of the things that's happening in the U.S. is that these systems are all joining together and turning into huge multi-billion-dollar corporations, rather than the local hospital. The hospital in our neighborhood used to be Arlington Doctors Hospital. Then it became Virginia Hospital for the state. It's now the Virginia Mayo Clinic Hospital. The Mayo Clinic is 10 states away, but they're connecting in ways to give them credibility, to give them access to resources, and to become huge corporate structures to deliver the care. So we're looking also at being able to anticipate risk. In the past, our model has been that you take care of people when something happens to them. Our drive now is to prevent the risk, to avoid the illness, and to treat people in a way that you prevent the illness from ever occurring. And we also know that we need to have interprofessional practice and teamwork. Teamwork is a huge new driving force in education and practice. Now, why do we want to do that? Why do you want a team? Because you get better results when you come together as a team, much better results, and you protect people in a very different way. Whoops, I gotta stop it. Hold on. As cute as it is, and you know what that is? It's an ad for, there we go. It's an ad for a Swedish bus company. You should travel in groups, but I just thought it's a wonderful analogy for teamwork. And one of the interesting things that we know about teamwork is, again, the fact that in medical errors, the major cause of what are called sentinel events, where something bad happens, is a lack of communication across providers. The literature is very clear. When a nurse sees something and doesn't tell a physician because he or she is intimidated, or the physician doesn't communicate with another physician, or the pharmacist doesn't really check the drug, when there isn't this connection of the pieces. And none of us can do it ourselves. We have to have the village, we have to have the team. And that's a major way to prevent the kinds of errors that we have been seeing, and to improve the efficiencies and the value and the outcomes of the care. So what are the essential competencies for the future? We're certainly going to always need absolutely exquisite clinical skills. We need to understand that our knowledge is limited and that we have to continually seek knowledge and be continuous learners. We also know that it requires collaboration in order to do the right thing for people. And we need to look at the big picture. And one of the big drivers these days is what we call big data, and gathering data about populations, about groups, and looking at the people you're caring for. What's happening with all my diabetic patients? Are they all getting the kind of lab work? Are they getting their hemoglobin A1Cs? Are they in fact getting their eyes checked? Have we checked their vascular structure? What are the outcomes of my care? And am I missing something in the care I provide to people? So big data is hugely important these days. So what's the future? I don't know. You don't know. None of us know. You know, the future, I always love it when we work with futurists because they work from the lens of now and what you know right now. That's the only lens you can work from. But this gives you some sense of how good futurism is. It says, scientists from the RAND Corporation have created this model to illustrate how a home computer could look in the year 2004. How many of you got your...
50 years ago.
That was in 1954. And that's what they thought the computer would look like at home. Now it said, now the needed technology is probably not going to be economically feasible, but with Fortran language and teletype interface, and they sure it would work. How many of you have your computer in your pocket? So we have no idea what the world is going to look like 2 years, 3 years, 4 years, 5 years from now. But we know it's going to be different. And we can't be like this, where you say, do I really have to change my prescription? I found the world looks so much better when you can't see it clearly. We've got to see it clearly. We've got to be on top of it and watch it and understand that change is going to occur. But change won't just occur. This is an interesting statement by Andy Warhol. They say that time changes things, but you actually have to change them yourselves. Interestingly, Andy Warhol died from a medical error in a hospital. So we have the responsibility to change things, to be open to the future and what it's going to look like. It will not look like what we know now, but it will be there for us to experience and live and shape. So thank you for having me.
Thank you, Polly. And we want to have a bit of a discussion. It might be a bit difficult across the sites, but open for discussion, and when people call out a question, I'll repeat it into the microphone so that everybody can hear. My first question, Polly, is why do some of the employers not have to provide health care, as you said, the target workers?
It's not a legislative requirement. It's always been a benefit that's been there, and it varies quite dramatically. In some places, the employer will pay for the employee and his or her family. In some places, it's only the employee. Since it's not a mandated requirement of employers, and if they don't have an active and unionized workforce demanding it, or the workforce is not able to unionize, they just ignore it. Interestingly, one of the things Walmart has done is, it's a phenomenon in the US that we're seeing now, is the development of store-based health clinics, where nurse practitioners, the CVS drugstore chain has what are called minute clinics, and they hire nurse practitioners to work in their clinic, and you can walk in, and they're open 7 days a week with pretty good hours, and it's really quite convenient. When I cut my foot on a Friday evening and I wasn't going to be able to get to see a provider for who knows how long, I just went down the street to the drugstore and got my tetanus shot. And I was able to get it there, and she took a history and did that. Well, Walmart is beginning to get into that same business of putting in the store-based clinics, and they are subsidizing their employees going there for health care. Now, unfortunately, that's not the kind of health care you want. That is, again, reactive, acute care, episodic approaches rather than thinking about health and trying to create the different health outlook for their employees.
Marie.
Thank you very much for an interesting presentation, particularly about patient-centred care. We've heard a lot about patient-centred care here in Australia, but it's interesting how it becomes translated. For instance, we had an interesting case recently about changing handover, where handovers delivered at the bedside with the whole multidisciplinary team attending handover at the bedside. However, basically it looks as though, it appears as though the central physician, if you like, is still in control. The patient has nothing much to say.
And they talk over the patient's head, right?
And move around the ward, and this is newly called patient-centered care.
Yeah.
So it's a long way from the ideal, even though everyone's trying. You know, the amount of change in our thinking as a health professional is going to have to be phenomenal. It actually shifts such a large system.
And we might just say that
Absolutely.
did people interstate hear what was being said? No. Yeah, Marie Johnson, the Associate Dean Research, was talking about people coming together around the bedside, giving handovers in front of the patient, talking patient-centred care, but not really delivering as such. Did you want to sort of...
Well, and I don't want you thinking that because we're talking about it a lot in the U.S. that it's any much better than that.
No.
All right? Okay. I do think one of the things that I'm very excited about that is occurring is that in the big systems who are having to deal with having their patients surveyed to see whether or not it's going to affect their reimbursement, they're beginning to pay more attention to this. And it's a big hit. You can have an 8% cut on your reimbursement based on whether or not that's a lot of money. And so the big systems, I'm on the board of a large healthcare system called Catholic Health Initiative, and one of the things we do is we look at the patient satisfaction surveys for the settings, the clinics and the providers. And we then rate the providers and say your ability to maintain employment here or your own salaries and your own merit increases will be affected. So more and more there are drivers focusing people toward that. You know, the other good news is that there are people in healthcare who really do care about the patient, who want to be a partner with the patient, and those people are being brought to the front. And so we're seeing a lot of exciting good things to happen. And we know that in an instance where you're talking about, although they may be thinking they're doing handoffs where they're all talking like this over the head of the patient, in the end they're not doing good handoff, and then you see the bad outcomes again. And people are being held accountable for that. So we can hope, you're right, it's a culture, and the culture that existed 25 years ago, 50 years ago, as one dominant provider being the seer on top of the hill, telling the captain of the ship, they call themselves sometimes, that is in fact going to die. One of the interesting things, too, that we see that may have a big effect on healthcare in the U.S. is the gender distribution is shifting in physician workforce. There are more women in medical school than there are men. And they actually do come in with a different mindset that is shaping if they can maintain their hold on that and not get socialized to the other side along the way.
Yes.
I just wanted to ask you, when you said the number of nurses are exploding in the US, both at the basic and advanced level. In terms of the professional placement of nurses, of trainee nurses, would you like to make some comment about some of the major issues in that and what are some of the more innovative approaches?
Sure.
The question is around clinical placements for large numbers of nurses, I think was the question.
Well, a couple of things. Let me ask, are you talking about where we train them in clinical placement for training? It's a huge issue for us. Now, some interesting things have happened in the last 5 years. One is that the same Institute of Medicine that did the report on quality and safety did a report titled The Future of Nursing, Healthcare in the U.S., The Future of Nursing. And one of the things that report said was that we need a better educated workforce in the United States, a nursing workforce. And as you know, we have the 2-year colleges, we have a few hospital-based programs still around, and then baccalaureate degree granting programs. And what this report from the Institute of Medicine said is that the evidence is pretty clear that the care is better and the outcomes are better when you have a better educated workforce, and therefore work has to be done to get at least 80% of the population of nurses at the baccalaureate or higher degree level. Now, we also, with the recession that we had, nurses were graduating and not finding jobs as easily for a while. And what happened then is that the employers who actually only wanted to hire people with a baccalaureate degree were saying to the community college graduates, we don't have a job for you. You don't have a job. So they were hiring all the better educated people because they now had the luxury with the cutbacks in healthcare spending to hire who they wanted to hire. Now, they also have been doing things like saying we're not going to give clinical training access to the community college students. Well, our first preference is going to be the better educating programs, and so that's happening. The bigger problem that we're having about clinical training is at the graduate level for people who are being prepared to be nurse practitioners and nurse midwives, because we are competing with medical students for placement, number one. Number two, and I just learned from Michelle yesterday that you all pay for clinical training. We do not. We do it on the goodwill of the clinical site's willingness to have our students come in and learn there and be mentored by the clinical staff there. And I think you would put cold chills in the heart of every dean in the country if they knew how much money you spend on clinical training.
I told Polly we spend $10 million a year on clinical supervision.
That just, every now and then, the sites say, well, you need to pay us to send your students here. And part of the reality of why, particularly with the graduate students, they're saying this is because having a learner in the environment impacts productivity. When you have a learner in there who's trying to get that first assessment done in a skilled way, and has to go back to the preceptor and say, can you help me here? It slows them down. They don't see as many people. They can't get quite as much care delivered. The other issue here is that you might be a fairly sophisticated student far along in your program who can see a patient and manage to look at that person, take a history physical, make an assessment, make a diagnosis, put together a clinical plan. But because you're not a licensed provider, you can't bill for it. So you have to do it, and then somebody else has to do it so it can be billed for. And so they're saying, you're really hurting our productivity, and by the way, our productivity is what keeps us alive and brings the money in so that we can operate.
And that's nursing workforce, and I asked Polly the other day about the workforce in allied health, what we've got physios and allied health people in
Well,
today,
it's the same.
what level are most of those practitioners in the acute care areas?
Well, in
Or community?
it depends on the allied health provider. Physical therapy is at the doctorate level now. They're moving. Now, there are a lot of people who have master's degrees who were educated before, but the programs are all moving to the doctoral level. The doctor of physical therapy. Pharmacy has been at the doctoral level for about 15 years now. Pharmacy used to have baccalaureate degrees, master's degrees, and then the PharmD. And they said to us one time, we suddenly looked at ourselves and realized we were looking like nursing, and we wanted one degree. That's a little knife to the heart again. But there are people like radiology techs or laboratory technologists who are doing community college education, the 2-year education to do that work. So it varies. But for those more independent type disciplines, they're moving to the doctorate. And in nursing, we are working to transition our highest level of clinical practice training to the Doctor of Nursing Practice. And that's going in fits and starts, but it is moving in that direction. So it depends on the provider. And as I look at you here, speech pathology is moving that way. They've been having a lot of conversation about this in occupational therapy. Midwifery has never really believed that they need to keep up with the rest of nursing. Midwifery, when we were moving to the master's degrees for the midwifery training, midwifery said, well, we don't need that. We just need a certificate. And then when we moved to the doctorate degree, they said, well, we just need a master's degree. So they're kind of inching along little by little to get there. Yeah.
So, I'd put it to the group and to you, Polly, do all the clinicians need to be at doctorate level?
No, I don't think so. But let me just tell you about nursing, all right, and why we've moved to the Doctor of Nursing Practice. One of the things we did was look at the curriculum for people who are being educated to be a nurse practitioner, a midwife, a nurse anesthetist, or a clinical nurse specialist. And when we looked at the curriculum, we realized that the programs were getting bigger and bigger and bigger. Now, that wasn't serendipitous. It had to do with the content that needed to be in the program to prepare these individuals to do the kind of expert clinical care they were delivering. You can get a master's in business administration in the United States for 36 semester credits. The average number of semester credits in a nurse practitioner program was 69.
That's units.
Units
Or
are,
subjects.
yes, like yours. So it basically, you were taking twice as many courses as anybody else who was getting a master's degree, and you were only being granted a master's degree. So to some extent, we felt like people were not getting the degree that represented the kind of time and energy and expense they were incurring to get the degree. The other issue here is that we were preparing people who were expert clinicians at doing individuals' care, working one-on-one with individuals. But in the meantime, they were missing an enormous amount of other things, like, again, understanding data and how to use data to manage your care, how to understand the systems and manage the systems that your care is going to be delivered in so that you can drive the right change, having the ability to look comprehensively at populations. And so we needed to add things to it. And again, adding and not giving them degrees that reflect what they're investing was wrong. So it was a rational move for nursing to move there. PharmD had the same issue. The pharmacists in the U.S. talk about doing clinical pharmacy, and they manage populations of hypertensive patients. They do, if you go into one of the pharmacies in the U.S., your pharmacist will sit there with you and talk to you about your medication for your diabetes. They do immunization clinics. They're doing, they're not just, what they used to call it was, if you could count to 5, you could be a pharmacist, because you could buy pills in the bottle, 5 pills in the bottle, 5 pills in the bottle, and you just read the prescription, 5 pills in. They're really into clinical science pharmacy now, and they are the absolute best partner for when you are providing care to people. I'm a nurse practitioner, and I haven't practiced as a nurse practitioner in years, and I'd be unsafe. You wouldn't want to come see me. But I, at one point, thought, I'm going to go back. I'm going to get my license again. I'm going to go back. And one of my colleagues, who was the dean of one of the nursing programs, said, come in and sit in on the coursework and audit the coursework. Then we'll get you some clinical training, and we'll help you go back, and you can recertify and become a nurse practitioner again. It was like drinking with a fire hose to try and get the drugs and the technologies, and I just didn't have the time. So that clinical pharmacy degree was the perfect partner for making sure we do that team-based care and that we bring the full array of resources for the patients.
Can we go around the other states and see if there's any questions? Brisbane?
Peter Rosignol from Brisbane. I'm an exercise scientist and an exercise physiologist. And I was just wondering what the situation was for clinical exercise physiology in the United States as far as training is concerned.
Well, this is he said, what's the situation for exercise physiology science in the U.S.? And I don't know that we have the equivalent in the U.S. We do have people who are trained for sports exercise management, who are doing the kind of sports science where they're going to work with tennis players or work with football players. But we don't have exercise science other than the physical therapy programs, which is a little different that you're talking about.
Which we call physiotherapy.
Physiotherapy, exactly. So, and those programs that I'm talking about are at the baccalaureate level in the academic institutions.
So, Peter, don't go to the US.
No, we're more developed here, apparently.
I think you are. You're more developed in many ways here than we are. And we're willing to admit that.
Anything else in Brisbane?
Thank you, no.
No, okay. Ballarat?
It's Rosemary speaking. Thank you very much, Polly. That was fascinating.
Thank you.
The thing that worries me is really huge organisations, and you talked about the hospital in Virginia becoming this multi-state organisation.
Mm-hmm.
That surely adds to the risk of error.
Well, one of the things I can tell you is that I actually think it's decreasing the risk of error in many ways, because what we are doing, let me just tell you about the Catholic Health Initiative, whose board I'm on. This is a $20 billion corporation. It has 189 clinical facilities, employs something like 100,000 employees. It's huge, and it has the full spectrum, long-term care, acute care, the tertiary quaternary care systems. It's the huge array of system types. And I sit on the Quality and Safety Committee as a member of the board, and we look at outcomes consistently, and we have specific outcomes for the providers and for the sites, and we know where we have to go to improve. And it's because this corporation is so big, and again, granted, part of this is driven by reimbursement issues and the concern that we're not going to get the money we need if we don't do it right. Certainly that's a driver. But it also has to do, for the Catholic Health Initiative, with the underlying values that they have. And the values are reverence, integrity, compassion, and excellence. And they believe they live those values by being sure that we do the right things for people and give people the care that they need and deserve at the highest quality. So having the corporate structure is actually making it easier for us to have a leverage on this full array of sites, and it's improving care in significant ways. They have a chief nurse officer for the system, they have a chief medical officer, and these people are exquisite partners and are modeling at the local level this notion of team-based work and partnerships, and the data that we get is culled through over and over. So it's actually giving us a level of sophistication about monitoring quality that we wouldn't have if we were just one little hospital with a staff of people.
Thanks, Polly. And Melbourne, any questions?
Sorry, Michelle, just another question from Ballarat.
Sorry, yes, stay with Ballarat.
Thanks, Polly. Lisa Clinic here. I'm just wondering, I'm an aged care specialist nurse, and I'm very interested in the person-centred care approach that's going on that you spoke about in acute care. But I'm interested in, is that translating over to the aged care sector? And I'm also interested in how do you break down those barriers in regards to the domineering or the dominance of some of the health professions that we work with?
Well, first about aged care, I think, I don't know if you are talking about long-term care or skilled nursing facilities where people are in a facility. That continues to be a big problem. Most of the long-term care settings in the United States are for-profit, and what drives them working is to make a profit. There's very poor nursing care or nursing staff. There might be one nurse for a system, one nurse that's on day shift, one registered nurse on day shift for a long-term care facility that might have 100 patients in it with really severe chronic illness. And so it's a huge problem, and it's a part of the problem is that there isn't a good centralized payment structure for it that might drive some of the incentives. Where those do exist and where they're part of systems, as I was saying before, we're beginning to see improvement in the long-term care settings. Now, care of the older adult has been a huge issue for healthcare professionals across the spectrum, and that's where most of the costs are in healthcare these days. And so there's a tremendous effort being made now, again, to keep older adults healthy, even if they have multiple chronic diseases, to keep them as healthy as possible and cut down their use of the healthcare system, and to be sure that when they are using it, it's being done in a way that's the most efficient and effective. Now, how you change the dominance of one particular professional is, I think you have to work with other providers to demand a culture in which all of you are treated as equals with different skills. And that means, again, just beginning to start at the individual and the system level to create an expectation for people getting along. I would throw data at people. The data are pretty clear. When you don't get along, that's when errors occur. That's when bad outcomes occur. And the research and the literature from the Joint Commission and others is very clear. That's when problems occur and when patients are harmed. So bring the data and say, look, either we partner or else it's not going to work, and you're not going to get the outcomes you want here.
Thanks, Polly. Ballarat finished?
Yes, thanks, Michelle.
Thanks, Rosemary. And finally, Melbourne.
Thanks, Polly and Michelle. No, we don't have any questions in Melbourne.
Thank you.
Okay.
Lastly, here in Sydney, to finish off, any last comments or questions? Susan.
I just want to know something about the mental health processes and systems in America at the moment.
The question is asking about mental health services or systems in the US at the moment.
It actually is a tremendous problem in the U.S. One of the things that's been documented a whole lot recently is the lack of inpatient care facilities for people who have severe mental illness. There was a situation in my state where a member of the state Congress legislature had a son who was a paranoid schizophrenic who attacked his father and tried to kill his father when he was having one of his paranoid delusional breaks. And his father was injured, and when he realized what he had done to his father, he killed himself. The father had been trying to get this child into an inpatient facility for months, but there were no beds. No beds. We are seeing a very big focus on preparing a huge array of other people to do psychological care, to do mental health care. One of the things that is driving this is the issue of our war veterans coming back from Iraq and Afghanistan, and the huge incidence of traumatic brain injury and post-traumatic stress disorder, which is a terrible series of illnesses to experience, but it's putting a spotlight on the deficits in mental health, and there has recently been some efforts to improve and expand access for those, but it's a huge need. One of the areas of clinical practice at the advanced practice nursing level that's seen some growth because of this, and the Veterans Administration has helped drive this, is psychiatric mental health nursing at the graduate level. So it is a problem. We're not doing a good job here.
Okay, well, it is nearly 6:20, so if there are no questions, I'd like you to join with me in thanking Polly Bednash for this really insightful and interesting presentation and discussion. We've enjoyed learning about your system and comparing and contrasting where perhaps neither country does anything particularly better than the other.
Some places, yep.
Yeah. But thank you for coming all the way out here and speaking to us, and we've enjoyed having you, Polly.
And thank you for having me. This has been great fun. I really appreciated you taking the time to come and hear me. And now we can go have some wine.
Yeah.